Welcome to EMDR, the science behind the therapy, a podcast from the Sonoma Psychotherapy Training Institute. I'm your host, Dr. Andrew Leeds. In each episode, we explore the latest research and clinical insights about EMDR therapy, highlighting the leading scholars' latest contributions to EMDR research, education, and training. Whether you're a therapist, a student, or a lifelong learner, I'm here to connect you to the science behind the practice of this remarkable form of psychotherapy. I welcome your feedback and suggestions for topics to be considered or any issues you encounter in my summaries of the research. You can reach me through the Contact Me form on any of the websites listed in the show notes. Before we start, I want to let you know about the unique EMDR therapy training delivered by Sonoma Psychotherapy Training Institute. Sonoma PTI provides a comprehensive program in 4 two-day modules spread over a 12-week period. These 4 modules include all required hours of lecture practice and group consultation. Our Zoom-based program is open to clinicians from throughout the United States, Canada, and Europe. I invite you to look over our curriculum and training schedule at sonomapti.com. In this month's podcast, we cover some of the latest research on EMDR therapy for medical trauma and grief from poster sessions at EMDR Europe's 2026 conference in Oslo, Norway. There were far more posters than I could possibly cover. To focus on the emerging science, I selected only quasi-experimental and controlled pilot studies, leaving out the many single case reports and case series. You will find a list of references and links to each of the authors of these poster sessions in the July 2026 blog on sonomapti.com. A link to these references can also be found in the show notes. After these interviews, you will find an invitation to join a free beta program for adding measure-based care to your EMDR therapy practice. So let's get started with the background to today's episode on EMDR therapy for medical trauma and grief. At the June 2026 EMDR Europe Conference in Oslo, Norway, during breaks between keynote presentations and workshops, I carried out several interviews with authors of new treatment studies. These are as yet unpublished treatment trials on important topics that are relevant in your clinical work with EMDR therapy. As I wandered the large poster area at the conference center in Oslo, I was struck by how many posters were from authors based in Turkey. This led to a first short interview with Zat Sifsi from Turkey. She has been based in London for a number of years, but she remains an active member of the board of EMDR Turkey and serves on their scientific committee. She told me how Turkey managed to be so well represented with posters at this year's EMDR Europe Conference. So, hello, Zat. We're here at the poster area, and I've noticed that there are many posters with clinicians from Turkey, and I understand that you are part of the reason that this has happened. Can you tell me about the story of how this comes about?
Thank you so much for your interest to begin with. We are so honored. And I am in EMDR Turkey board, and I'm a member of EMDR scientific committee, research committee of EMDR Turkey. I'm based in London for 9 years now, but I volunteer for EMDR Turkey Association online usually. I know that we have lovely colleagues in Turkey who are like strong scientific research women and also men, of course. And with Alişan Burak Yaşar and also Ersin Uygun, our psychiatrist, we said, let's make a project and let's encourage our valuable fellows.
And these are people who have not presented their work before. So the first time to create a poster session is a challenge.
We send an email saying, this year we'll be in Europe. Let's just present whatever we did. And they were like, would they accept it, or how we'll be doing the posters? So Shamrak Yaşar and myself help members of EMDR Turkey to do their best to present what they've done in their research work to reflect in the posters. And then today we are in Oslo, and we are so honored and thrilled that these great people have many of these posters here.
I'll be talking with some of the poster authors. Thank you for telling me the story of how it is that Turkey is so well represented in the poster session here this year.
Oh, thank you. We're so honored and thrilled with your interest, actually.
The first research interview is with Vanessa Grandjean. In this interview, I discussed the pilot study she and her colleagues from the Luxembourg Hospital Center carried out on the impact of the brief EMDR-trained protocol on trauma symptoms in patients undergoing treatment with chemotherapy for non-metastatic breast cancer. We're here in Oslo in the poster session. Would you introduce yourself, please?
I'm Vanessa Grandjean from Luxembourg, and I'm psychotherapist, and I'm here to present my trained protocol for patients with breast cancer.
So I see this was a pilot study, and you had about 50 patients, non-metastatic breast cancer. Tell me about what the research design was.
The design, we meet the patient just when they receive the diagnostic, and they receive after that chemotherapy. We have 50 patients with randomization, 25 have EMDR session and 25 just speaking conversation. We see them 8 times during the chemotherapy, and we look after that with quality of life, PTSD, depression, and anxiety. At this time, we have the results before and after chemotherapy, and at the end of this year, we received the result for 3 months and 6 months after the treatment.
Okay, so 4 measurement periods
Yes.
before the chemotherapy,
Yes.
at the end of chemotherapy, 3 months after, and a 6-month
Yes.
follow-up.
Yes.
And the second group had talk therapy? Or...
Yes, just talk therapy, how they feel.
All right, and then you use standardized measures for PTSD.
Yes, for quality of life and anxiety and depression. Because we see that with the literature that a lot of patients have big PTSD 3 and 6 months after the chemotherapy. And we try, when we do a precoce intervention, that we can decrease this.
All right, so they had a total of 8 sessions of EMDR reprocessing.
Yes, it's a new protocol because the patient, we see them during the chemotherapy. It's impossible to do long session. We can do just 20, 25 minutes because the patient is very tired. There are some side effects, and we try with EMDR to help them to cope with the treatment. We deal with them and we look what is difficult for them now, from the diagnostic till now, or when they think after.
So the targets included the diagnosis,
Yes.
the side effects from the chemotherapy,
Yes.
and other life stresses going on.
Yes, and the fear for the future.
So past, present, and future concerns. But the sessions were very brief, less than 30 minutes.
Yes, and we draw a train with the patient, a train with different wagons, because we think that when they receive the diagnostic, they go in the train, and the first wagon is the diagnostic. After that, maybe chemotherapy, radiotherapy, immunotherapy. And we help them to look in the train, in the wagon, before, during, and after.
Vanessa, you were explaining that because the women with breast cancer are going through chemotherapy, when you were providing EMDR, that you have to use a modified protocol, which you call the train protocol.
Yes.
Can you explain to me in simple terms what this train protocol represents?
And when we meet the patient, we speak with her about the story of the treatment, and we do a train with them. And we cut the treatment in some wagon, and we look with them when we meet them, where is the more difficulty.
So the picture of the train represents the different aspects of the treatment,
Yes.
the diagnosis, the surgery, the chemotherapy,
the radiotherapy, the immunotherapy.
And then you ask the patient to identify which of the cars holds the most disturbance.
Yes, it's maybe the car where they meet them. If we meet them during the surgery, We speak about the surgery. Maybe it's the car wagon before with the diagnostic, with the chemotherapy, but maybe the next car. And we speak about them when
So you select the
yes,
train car, the aspect which is the most disturbing,
yes,
highest SUD level,
yes,
and then you do an abbreviated session. You only have
yes,
25 minutes because they don't have the mental energy
yes,
to do 60 minutes.
yes,
They're not the stamina.
yes, because there are very maybe side effects. And when it's finished with the session, we look maybe it's 10 till 7 till 6. And when we stop, we give
So the SUD has gone from a 10
yes,
down to a 7 or a 6.
6.
So it's
Yes,
come down part way,
yes,
but not to a 0 or a 1,
no,
but you still go ahead with installation.
yes, because it's impossible for the patient to go to 0 because they're always in the train. And the idea that they need to stay in the train, so to give direct an installation with positive condition, maybe am I able to stay? Okay, I'm feel okay, I'm strong. And we look with the good feeling in the body and we
Right.
do the stabilization.
So I think that there's a general principle here that is important beyond the research results that you're able to achieve in the study, which is that because of practical limitations, it's unlikely that patients in this work can get to a 0 SUD or a 1 SUD or a 2 SUD.
Yes,
But even nonetheless, you do an installation,
yes,
possibly with a modified positive cognition, as good as they could have.
yes,
So it ends on a positive note.
yes,
But then you don't try the body scan. You know there's more disturbance.
yes,
And then the next time, maybe you come back to the same target, or if something else is more disturbing,
right.
you move on to the next
Yes.
aspect. It's
Yes.
the most disturbing.
Yes, and we look and we follow the patients. We follow the patient with some stress and we see what they want.
I see. And so in this way, you're bringing down the stress load that patients are carrying while they're going through
Yes.
treatment. It may not get to a 0, but there's still improvement.
Yes, yes,
So it's a practically focused
yes,
intervention.
yes.
It's not perfect,
No,
but it provides symptom relief.
yes, and some resource for the patients. It's very important when the patient needs positive resource, need help to be okay to stay in the train and to go for the next car.
And I think what's interesting in terms of the preliminary results that you have without the follow-up data yet in the poster session here, that the result that shows the greatest benefit is the quality of life.
Yes,
Yes. And this is the strongest benefit.
yes,
And I think this is because you give them hope, you give them a way of thinking more positively about their experience.
yes, right. Yes. And because the idea that to help the patient for the future with this.
And finally, I want to just comment with you about the possibility that you have of doing this type of research in your country because you have an integrated health system,
Yes,
unlike in my country in the United States, where with this fragmented system, many different players, many different insurance companies.
yes,
Here, if you can provide a benefit, the system as a whole, as
Yes.
well as the patient, benefits. So there's support for you to be involved in the hospital program. This is not possible in the United States.
yes. It's why for this that we can work together to help the patient.
So again, you're working at the Centre Hospitalier Luxembourg.
Yes, right. Yes, and we do research. We do this with the CHU Bruckmann in Belgium. We have tools for the research.
So in general, the major finding of the study showed no significant difference between the control group and the EMDR group on the time comparisons.
Yes, and this time we don't find no significant, but we hope that after 3 months, 6 months, because it's difficult to in 8 session we do session during 8 weeks to do direct to see a
So
significant effect.
you don't yet have the follow-up data.
Yes, not yet.
Okay, so this is the preliminary data from time 1
Yes,
and time
time-
2
yes.
only. So this is only preliminary
Yes,
data.
yes. And we publish when we have the T4.
Okay, so it's possible that there are some delayed benefits from the EMDR intervention, but you
Yes.
don't know that yet.
No, not yet.
No immediate benefits, no statistically significant differences
Yes.
between groups on any of the
Yes.
measures.
Yes,
This chart here, is this quality of life?
yes,
There's a bigger difference here than in some of the other charts.
yes.
This favors the EMDR group?
EMDR group is this with red.
Okay. So the EMDR group started lower
Yes.
and ended
Yes.
lower,
Yes.
and they maintained their quality of life,
Yes.
but the control group had decrease in quality of life.
Yes.
So that's interesting.
Yes. Yes.
So even though you did not see significant decreases
Yes.
on other measures, there was an improvement in quality of life.
Yes.
That's preliminary.
Yes. It's maybe saying that because we see just it's 10 years that I do this in hospital, and we see with clinical that improve. But we want with the research to say that maybe it's right.
Okay. Anything you want to add about your study?
No, I'm very happy to be here, and I hope that we can publish this in next year.
Well, I look The second research interview is with Leyla Kaya from Hacettepe University in Ankara, Turkey. With the support of her graduate advisor, she carried out a quasi-experimental study on the GTEP EMDR group protocol for women experiencing infertility. Forward to seeing the article when it's published. Thank you for your time.
Thank you. Thank you very much.
The second research interview is with Leyla Kaya from Hacettepe University in Ankara, Turkey. With the support of her graduate advisor, she carried out a quasi-experimental study on the GTEP EMDR group protocol for women experiencing infertility. So we're here in the poster area, and I'm at the poster of Leyla Kaya, who's done a wonderful study on the EMDR group protocol, the GTEP, for women experiencing infertility. Leyla, can you tell me about the background, what led you to do the study?
Okay. First of all, thank you for your interest in my study and for inviting me. My name is Leyla Kaya. I am a psychologist and EMDR therapist. This study is part of my doctoral dissertation. Some of the findings have already been published in the Journal of the Turkish Psychological Association. I chose this topic because women experiencing infertility face many psychological and social challenges. But these challenges are often overlooked. When women learn that they cannot have a child, they enter a very difficult process. They may experience emotional, physical, and financial stress. Many women feel ashamed, stigmatized, inadequate, or less valuable. Some women also withdraw from social life to protect themselves. In addition, medical procedures, treatment failures, pregnancy loss, and fertility can be very stressful and sometimes traumatic experiences. That's why I wanted to study infertility, and I believed EMDR would be helpful.
Wonderful. So that's a very clear explanation of the background. So can you tell me about your research design and how the project was organized?
Of course. To recruit participants, I first shared an online survey. Women experiencing infertility completed the survey. I used the infertility stress scale to identify women with moderate or high levels of infertility stress. After screening and interviews, we selected 14 participants who met the inclusion criteria. Participants were randomly assigned to two groups. 7 women in the experimental group and 7 women in the control group.
So the control group received no treatment at all,
Yes.
and the other 7 women received the 10 sessions of weekly GTEP.
Yes. Before the intervention, both groups completed 4 measures: infertility stress, infertility stigma, women's gender role stress, and self-esteem. The study used a quasi-experimental pre-test, post-test, and follow-up design. The experimental group attempted a 10-session face-to-face counseling program. The control group did not receive any psychological intervention. After the program ended, both groups completed the same measures again. 3 months later, we conducted the follow-up assessment.
So you have post-test after the 10 meetings
Yes.
and follow-up data as well.
Before, we also included psychoeducation. In each session, we discussed topics that women struggled with. For example, we talked about social expectations, motherhood, and gender roles. We discussed questions such as, does being a woman mean becoming a mother? And why should infertility make someone feel inadequate? In Turkey, motherhood is often seen as an important part of being a woman and marriage and family life. Because of this, women may feel pressure from relatives, friends, and society. During the EMDR work, we did not focus on childhood trauma or other unrelated experiences.
You focused around the infertility experience.
We focused only in fertility-related experiences, starting from the day participants learned about their infertility. We worked on difficult memories, triggers, emotions, and beliefs connected to infertility. We also used research development and future-related exercise to strengthen coping skills and look for the future.
And what were the main findings with the testing that you did?
At the end of the study, we compared these pre-test, post-test, and follow-up scores. The results showed that improving stress decreased, stigma decreased, and gender role stress decreased in the experimental group. Self-esteem increased. These improvements were maintained at follow-up. The control group did not show similar positive changes. In addition to the test results, we also observed important changes in the experimental group participants' lives. Many women started to see themselves as more than a attractivity. They became more confident and started missing the meaning life again. They started to focus on themselves again. For me, this is most important finding was the reduction for stigma. Being part of a group helped women realize that they were not alone and that their experiences were understandable. I also believe that processing infertility data to reference and triggers from GTM and participants were stronger and more resilient. Another interesting finding was that 2 women became pregnant 1 month after the program, and 2 more became pregnant 10 months later without IVF treatments. Of course, this was not the main aim of the study, and we cannot say that EMDR caused these pregnancies. However, it suggests that reducing stress and emotional burden may have a positive effect.
So in this study, you showed that there were dramatic improvements compared to no treatments.
The main limitations of the study were the small sample size and the fact that we were not included. Infertility affects not only money, but also relationships and couples. Future studies show include larger samples and small partners. Today, I continue to work with women experiencing infertility so that in community therapy and group observations. And I will continue to see more changes in their lives.
Well, thank you so much for explaining about the research you've done and for presenting your work here at the Oslo conference.
Thank you very much.
My third research interview is with Christoph Bajer, who was part of a team of 4 researchers from the College of Medicine of Jan Kochanowski University in Kielce, Poland. They carried out a pilot study on the early EMDR RTEP intervention for patients after myocardial infarction investigating the reduction of acute stress symptoms and the prevention of PTSD. So here we are still in the poster hall during the EMDR Europe Conference, and I'm standing in front of a poster on the early EMDR RTEP intervention for patients after myocardial infarction. One of the authors, Christophe, is here. And
Hello.
so thank you for being willing to talk with me about your poster.
Thank you, Andrea, for having this possibility to talk with you.
So what was the interest, what led to this idea to carry out the study?
What I can say about idea, as stated on the poster, was to give support to patients after incident.
You thought you might lessen their symptoms.
Yes, to lower a little bit symptoms of stress about the incident, because after we check the PCL5 and the other stress symptoms, we find it that they are very high. And after our stabilization procedure, they are much more comfortable going through the situation. We, of course, did that with the consultation of the medical staff.
Right.
Yes. Why we did it? We find it for us interesting subject, and it turned out we have possibility to make this kind of intervention. It is not so easy to find the place to do that. Thanks to that, we are from the part of Collegium Medicum, where one of the doctor interested asked us to design it.
Right. I'm aware of earlier research that a high percentage of patients after their first myocardial infarction, they will not take the aspirin because it reminds them of the trauma of their experience. And so if you can reduce the trauma load, then their health will be better. They'll be more medication compliant and improve their lifestyle and deal with their heart issues.
Yes, exactly.
So as it says on the poster, 15 to 20% of patients subsequently develop criteria for PTSD. So this is a good population to study. Now, the intervention that you used in the study was the RTEP. So that's the recent traumatic event protocol. And so these were individuals who were treated individually.
Exactly.
With subsequent admission to the study.
Yes.
One at a time. And how large is the sample that you ended up with?
It is 68 people. We have two groups. So one with the EMDR in the RTEP group, and the second was a control one.
About equal numbers in the treatment group and in the treatment as usual group,
Yes,
who did not have the EMDR.
It is almost equal, yes. The data we have here, it's the preliminary data for the first of all. Second of all, we are in the process of writing an article to make a data exact.
So I see that you used 4 instruments here.
Yes. We measure acute stress symptoms, anxiety, of course, PTSD, what is after and after follow-up, and thinning stress.
And so the chart that you have here is post-treatment.
It is post-treatment.
And there's huge difference on the PCL5.
It is really huge difference.
So on the PCL5, the typical average score in the treatment group is a 0.6, and in the control group, it's 2.8.
Yes.
So a dramatic difference, 6 times as much severity in the non-treatment group.
Yes, you're right.
And this is from one session?
No, it is after 4 to 6 sessions.
4 to 6 sessions.
Yes, the period is, I think, 3 weeks.
So over 3 weeks, 4 to 6 sessions.
Exactly. At the beginning, we have the week of introduction to this intervention. And after that, if the medical staff give us green light, we start the intervention with the patient. We don't have follow-up. They will be.
Right, so when you publish, there'll be pre-test, post-test, and follow-up data. So this is just a preliminary presentation of the data showing the largest decrease on the PCL5, but there's also statistically significant differences on the anxiety scale, big difference on the acute stress scale.
Acute stress, yes, exactly.
Right?
So we hope that it will be beginning of further controlled trials.
And is there any plan to conduct qualitative interviews with any of the subjects to describe the effect the EMDR had on their approach to life afterwards?
Honestly, we didn't had that idea, but it seems to be a very interested one. I will talk to my colleague and maybe we try find some interviews about it.
Okay, so again, one treatment versus no treatment. Maybe in the future, there could be a 3-arm study with a control group and 2 active treatments, something other than EMDR to show comparative treatment effects.
Exactly.
But as an initial study, this is a really important contribution. Thank you to you and your team for presenting this information at the conference.
Thank you very much. Thank you for interested in our poster, and thanks to you, we can spread out a little bit our preliminary information about this research.
The fourth research interview is with Ersin Ugun from the Applied Master's Program in Trauma and Disaster Mental Health at Bilgi University in Istanbul, Turkey. Ersin discussed with me the study of his master's student, Sukran Pelvan. This was a randomized controlled pilot study on the efficacy of an EMDR grief protocol on traumatic grief and emotional processing on bereavement following earthquake loss.
So we're here in the poster area, and I'm standing with Ersin Ugun, who has a poster on the efficacy of an EMDR grief protocol following earthquake loss. And this was a randomized controlled study. First, tell me, where are you based in Turkey?
I'm based in Istanbul University. I am a lecturer there on trauma mental health master program in Turkey, Istanbul. And that is a thesis study of my student, Shukran,
Oh, I see. So you are the second author,
test advisor
test advisor.
of that research. Yeah.
Okay. So can you tell me about the design of this study?
As 23, and it earthquake affected more than 10 million people.
10 million.
Yeah, 10 million. And lots of them moved to another city and to the biggest city of Turkey, to Istanbul. And my student was working in Ministry of Istanbul and was working in group which was giving psychosocial support to earthquake survivors. Then we wanted to test a brief protocol which developed by Roger.
This is Roger Solomon's grief protocol.
Solomon's grief protocol. And we structured it in a 3 long session, like 90 minutes. And we did it generally online.
Most of these sessions were online.
Yeah. And the people came from earthquake area to Istanbul. We had a list which came to Ministry of Istanbul to take support. And we randomized them. We took we list the intervention and control groups. We vote actually at the beginning 80%.
Right.
But then 2 of them was taking the steel therapy support.
Okay.
So we excluded them. Then
Right.
we randomized just 78 person randomized in 2 groups.
So there's 39 in the intervention group and 39 in the waitlist group.
Exactly. Yeah.
So they receive no treatment while they're on the wait list.
Yeah. Group was waiting, and the other group was taking 3 sessions of grief protocol.
Intervention was 3 sessions of the specialized protocol.
Exactly. Then after finishing the study, we offered to control groups, if they want, we give some of them the same protocol as well after finishing the study.
How many points of measurement were there?
Yeah, measurement was there. We wanted to test the effect of the grief protocol, but on the other hand, we were asking how it's working. We know there is adaptive information processing theory, and what is processing in that sessions. We wondered about emotional processing, how that sessions will affect the emotional processing measures as well. So we gave 3 tools: PCN, trauma grief scale, and emotional processing scale.
And this was done at just 2 time points, pre-test and
Yeah.
post-test after the 3 sessions.
Yeah.
There's no follow-up data,
No, there is no follow-up.
just pre-test and post-test data.
We are planning. Why? Because it's a thesis
Right.
and we have to finish it by the student, but we have the same connections and numbers of people. So we are planning to call after 1 year, for example, 1 year follow-up.
So there may be a follow-up study.
Yeah, to know if the
Stability of effects.
yeah, of course.
Okay, so then comparing the intervention with the control group on the PCL5, it looks like there was very significant improvements.
It's really working.
Okay, but not just on the PTSD symptoms, the TGS scale shows significant decrease in traumatic grief with this measure.
Generally, in the session, we observed that we were focused on loss, but all of them was a traumatic loss. So when we start to work on loss memory, generally it's connecting to traumatic event as well. So they started to processing together the loss and the traumatic events.
All right. And this third measure, emotional processing difficulties, is that a standardized measure or something that was developed for the study?
No, it's a standardized and it's common in Turkey. And it's from memory or no coping with memory, just thinking or giving, for example, how coping with memories, really looking emotionally and processing it, or just thinking and keep away the memory.
So then
relation.
not only does this show reduction in traumatic grief significantly and reduction on PTSD symptoms, it also shows a dramatic shift in attitude towards emotional processing.
Exactly.
So people become much more receptive to dealing with their experience
Exactly.
through this process
So
in just 3 sessions.
yeah,
They shift their whole stance towards the process of dealing with their inner life.
After 3 sessions, they were not escaping from memory. Or
They felt they could face their memories and face their feelings.
face to face, and they are looking to memory and they are looking to emotions. Because generally, when the score is traumatic grief score was high, they generally was just trying not to think about loss.
Okay. So with these individualized, administered, specialized grief interventions, I see that your recommendation from the poster session is that this type of EMDR protocol should be integrated into post-disaster mental health responses.
Exactly. For example, there were many interventions developed by WHO like PM Plus or IPT. For example, there is SOLAR and culturally adapted CBT. Many of them doesn't have any strategy for grief.
For traumatic grief.
So they are targeting stress symptoms, depression symptoms.
It deals with the relationship between the individual and the event, but not their traumatic loss.
Yeah,
And that's what's different about this protocol.
exactly. So maybe that protocol in 1 or 2 sessions can adapt to PM Plus or to SOLAR or to culturally adapted CBT. So they work together because it's a really good strategy. It's so hard to work the grief in disaster field, disaster area. So it's, I think, strong tool, and we should protect it. And we should test that protocol with a more huge group, with big RCTs.
Right. And it would be nice to have an active treatment comparison in the future so that EMDR versus some other intervention, one of the ones you mentioned perhaps.
I hope we are working.
Thank you very much for the time to discuss your poster.
Thank you so much. It was really very nice and enjoy discussion for me as well. Thank you.
That wraps up the interviews I conducted at the poster session during the 2026 EMDR Europe Conference in Oslo, Norway. These posters addressed EMDR treatment of grief, infertility in women, myocardial infarction, and women with breast cancer. In addition to the references for these 4 posters, You will find additional peer-reviewed journal articles for these 4 topics listed in the references for episode 12 of the podcast for July 2026. Before we close, I want to let you know about a new service that provides free online access to a set of standard measures you can implement in your clinical practice or use for conducting your own EMDR treatment outcome case series research or single case reports. Have you thought about using measure-based care in your psychotherapy practice, but maybe haven't been sure how to get started? I learned about this new service through my local psychological association. I've begun using measure-based care's tools and have found that they are remarkably easy to use for me and my patients. The MBC service is currently in beta testing. They are inviting clinicians to help them develop a service that is genuinely useful and affordable for real-world practice. If you join them during this beta phase, the platform is completely free for the first 20 users for 6 months. After that, they will transition to a simple freemium model designed to support clinicians at different stages of their practice. Clinicians will be able to use the platform free of charge with up to 5 actual patients, and as your individual caseload grows, their fee is $9.99 per month for 6 to 20 patients and $19.99 per month for more than 20. For large organizations or group practices, they'll be offering custom enterprise pricing. They are creating a friction-free, measurement-based care tool that easily fits into your clinical workflows. They offer alcohol and drug screening tools, as well as the GAD-7 for anxiety, the PCL-5 for PTSD, the PHQ-2 for depression, and the PHQ-9 for general health. At my suggestion, they have added the MID-60 for screening for dissociative symptoms and the full MID, so EMDR-trained clinicians can easily screen your patients for dissociative symptoms and disorders. Automated assessments and check-ins can be sent out on the schedule you set so you can collect meaningful outcome data. They've made it easy for your patients to engage. They can respond by voice or through quick, simple forms on a smartphone, tablet, or computer in either English or Spanish. You can use their existing standard measures or bring in your own custom measures depending upon what matters most in your practice. They've made documentation easier too with easy data exports. You get real-time dashboards that highlight engagement, progress, and potential non-response. You'll be able to start each session with a clearer, data-informed picture of what's actually changing. You can zoom in on individual patients or step back and look at your entire caseload. I can tell you from my own experience that they would love to have you involved. Their technology lead, Abhi Iba, is ready to help you with onboarding and offers videos to demonstrate how to use MBC's features. You can locate their website and email support details in the show notes and in the resources section at the end of this month's reference list. That's it for today's episode of EMDR, The Science Behind the Therapy from Sonoma Psychotherapy Training Institute. We hope this podcast helps deepen your understanding of the clinical science behind EMDR therapy. Links to all the studies covered in episode 12 of the podcast can be found in the show notes and at snowpti.com/blog in the July 2026 listing. If you enjoy this podcast, help support the podcast by following, reviewing, or sharing it with fellow therapists. For information on our unique EMDR therapy training program, visit sonomapti.com, and for free articles on EMDR therapy, visit the resources section on andrewleeds.net. Thanks for listening. We'll see you next time.